Crohn's disease, a patient journey. May I have the slides? Okay. What's important here, we need to know that the early diagnosis and the prompt institution of treatment are the cornerstone now for improving the outcomes of our IBD patients. And so for early diagnosis, we have red flags. And then following that, you are having to have clinical decisions, tools to go for personalized medicine. Our case is an 18-year-old female presented with abdominal pain and weakness and easy fatigue with weight loss and diarrhea for the last 6 months. Clinical examination showed pallor, tenderness in the right lower quadrant with no palpable basis. And this is the endoscopy. The lab results showed hemoglobin of 11, MCV hypochromic microcytic, CRP is high, but a little bit high, calprotectin 700, and stool analysis showed plus cells, but no ova or parasites, CT hyperenhancement of in T1, and terminal ileoscopy showed multiple aphthoid ulcers, as you can see. Histopathology showed that patient have Crohn's disease. So according to Montreal, this patient is having Crohn's disease, Montreal A2, because it is above 16, and L1, which is iliac, and B, which is inflammatory. What you are going to do, first, we are trying to diagnose early because there is because of this delay in France, in Italy, in Switzerland, we can expect our delay here. They invent something called red flags, and this red flags questionnaire. This questionnaire, if the patient pass 8, and in this items, then you should refer the patient to the gastroenterologist right away because the patient could have early Crohn's disease. So, and also they tried some papers done after this because this was suggested by IOBD, International Organization for IBD, in 2015. And after that, they said that if you measure the patient calprotectin level 40, that means that the patient will have less than 1 probability to have IBD, because very low calprotectin is having, so it could be an excluding diagnosing of IBD. But if you use the red flag index as well as the clear calprotectin above 250, that makes that the negative predictive value is 100%, and the positive predictive value run from 40% to 20%. So what we are going to do for management of those patients, we have these patients, we have predictors of course disease, who are risky, who are bad, and then after that having our treatment target, and then algorithm for this target, and monitoring the algorithm after doing that. And this is the current, as you already have seen, STRIDE, and this is the primary first thing is try to stratify your patient and knowing the risk of this patient, because now we are going, as I told you yesterday, that there is the difference between activity and severity, and activity means now, severity means that the history of the patient and before that, and according to this risk, we have seen it yesterday that the Crohn's disease, those patients who are having bad risk should have bad risk. Those will have less risk will be treated differently. If you apply this to our patients, the severity of low risk, because this is the first time. Activity, it is mild to moderate. So if we are saying this is low severity and mild, so that means that it is mild progression possibility. But if it is moderate, it will go for the moderate. So our patient in between 2. So this is the last month in AGA position in therapies IBD. And you can see that those patients who already have mild, moderate disease, you can, asymptomatic disease, whether it is, if it is incidental and the patient is asymptomatic, you can follow them up no pharmacology at all. If, by the way, the patient is not complaining, you find calprotectin high, do endoscopy, find these outside ulcers, you can follow this patient up. But if the patient is symptomatic or mild, then you can give budesonide course for 3 months. If it is left side, if it right side, if it is left side, you can give sulfasalazine for same time. If improved, that's fine. You stop after 3 months, no treatment after that. But if there is recurrence, for re-evaluate after this. And if there is recurrence, you move to the next step as a moderate disease. Why that? Because this paper also, it is published last month, that patients having early Crohn's disease, 30% of them can move into a very slow course for the rest of their life. So they maintain their early indolent course, which is slow, no progression, and not need to go for further treatment. So our patient give him budesonide, and after budesonide she was okay, stopping her treatment, clinically asymptomatic for a year, and then return back with recurrence of symptoms, hemoglobin anemic, micro, hypo, CRP high, and high calprotectin. This is endoscopy, showed the classic Crohn's disease now with severe ulceration, coupling, stoning, impending stricture. And so this score with those pirates is SES score, simplified score, we got 10, which is extreme. And here you can see the CTE showing edema and hyperenhancement. That means that the patient went from now, because we have now history, so it is severe, activity now moderate, and then that means we went to this here. The patient is having high risk, high severity, moderate activity. Then we expect in the future that he will have severe course. So that means that we need to intervene. And this is the moderate patients having terminal disease. Then you should have either one of two things, either TNF plus or minus immunosuppressive, or you can go for cell resection, which is the ileal chronic resection. But this is resected, this resection is put for the patients, old patients with a typical feature, or there is a sort of patient need that he decided, okay, I'll take it out and I'm not going to have treatment. This option could be given to this patient. So you are going to give the patient position now, what you should do. First line, TNF plus or minus combo. And otherwise, if there is a patient risky infection or whatever, then you go for secukinumab or vidofludimus. First, if the patient is severe, go for secukinumab. Moderate, you can give vido. So the patient has been given adalimumab plus azathioprine combo treatment to reach our target, and apply this targets is short-term targets, which is symptomatic improvement, and then intermediate targets, which is the CRP normalization, as well as improvement of calprotectin. And here is starting of endoscopic mucosal healing as a last target. And same thing, biomarkers are okay to help us in managing those patients, but we need to know that, as we said, calprotectin at the index. This paper has been said by the last foreigner presenter, Dr. Ilza, that the patient already have, if you already have calprotectin at the index visits of Crohn's disease, should increase rate of progression, and achieving less than 250 within 12 months of diagnosis associated with good reduction of disease progression. Also, you can monitor by ultrasound And this is the point of care interest in ultrasound by thickness and Doppler, as well as wall layer stratification. And there is a score has been called bowel ultrasound scoring system that now can predict and this is compared with CES score for by endoscopy, and shows that even ultrasound is much better target than even mucosal healing. Also, MRI could be a target of monitoring of those patients, but this is sensitive, and you have here about the Maria index for activity, also Lehman index for the damage, as well as the MRI for the fistula program. And this is it's been published last month also that should be included in monitoring our patients' imaging targets by either ultrasound or MRI. Go back to our patients. The patient is now asymptomatic after giving this treatment, has been normalized by CBC, CRP, and calprotectin, all well normal. Then what? Endoscopy, as you can see here, the cecum is okay, and this is terminal ileum is okay. And the video, I think, here, showing the terminal ileum mucosa, and has been mucosal healing after taking the combo treatment, TNF, adalimumab plus azathioprine, and the patient histology-wise is healed. So we got complete mucosal healing, but for our interest that we said, okay, let's confirm that with the MRI, whether it is the same or not, because it is transmural disease. And we astonishingly found a lot of things, impending enterovesical fistula and polyps and edema and whatever, also only predicted by ultrasound and by MRI and not by CT. That tells us that we should follow tightly our patients with not only clinical or inflammatory marker, or MRI is needed, as well as endoscopy. And as we know now, is Crohn's disease is a transmural disease, and not even be satisfied with the endoscopy healing, because even endoscopy healing could not be that important. So, and that's why that had been put here, that the target transmural targets is now our next target. So try your best to reach mucosal healing, but if you detect that still the patient is going on, so the patient should continue on treatment. And the conclusion that early diagnosis and early management of IBD are critical, because it will minimize complication and ensure that the position of patient outcome will be okay. Selection is approach for the first line, should be risk assessed, and then disease activity and the clinical characteristics of the patient are what we need. Thank you very much.